This is Eric from Strong Medicine, and in this next to last video on antiarrhythmics, I'll be talking about the unclassifiable drugs, specifically Digoxin, Adenosine, Atropine, Isoproterenol, and Ivabradine. I'll go through each one at a time. So let's start with the oldest one, Digoxin. Digitalis purpurea, also known as the common foxglove, is a flowering plant originally native to Europe, but now it can be found in parts of North America. It was first used as a treatment for heart failure in the 18th century. In itself, that's pretty remarkable, given that its beneficial effects in heart failure are very modest and would seem to be below the limit of detection using just non-systematic subjective observations. In the 20th century, various compounds of similar structure and effects were isolated from related plants and are now collectively known as cardiac glycosides. Of the cardiac glycosides, Digoxin is by a large margin the most well-known and most widely used. To understand the mechanism of Digoxin, I'll need to review an aspect of normal cardiac physiology we haven't yet discussed. In all cells, there is a sodium-potassium ATPase, also called the sodium-potassium pump. This transmembrane protein pumps sodium out of the cell in exchange for potassium entering the cell. This helps to maintain the normally high extracellular sodium concentration and the high intracellular potassium concentration, and also helps to maintain the normal negative resting membrane potential. Because this translocation of ions occurs against electrochemical gradients, energy is required in the form of ATP. There's another transmembrane protein in myocytes which acts as a sodium-calcium exchanger. This exchanger can trade sodium for calcium ions across the membrane in either direction, depending upon the electrochemical gradients of each at that moment. Digoxin works by inhibiting the sodium-potassium pump. The most proximal consequence is that the intracellular sodium increases. This leads to a lower gradient driving sodium into the cell, which means less calcium is being exchanged out of the cell. So intracellular calcium increases, that is, cytosolic calcium increases. If you recall from lesson 3 in this series, high cytosolic calcium promotes further release of calcium from an intracellular structure called the sarcoplasmic reticulum. In turn, this strengthens myocardial contraction. While this mechanism doesn't seem directly relevant to its antiarrhythmic effects, it does explain a significant portion of arrhythmias caused by Digoxin, as the elevated cytosolic calcium can lead to a phenomenon called delayed after depolarizations. After depolarizations are discussed in my video on mechanisms of arrhythmias. There is a link in the video description. Through a separate, incompletely understood mechanism, Digoxin also increases vagal tone on the heart, which leads to slowing down of the sinus rate, an increase in the duration of the AV node's refractory period, and a decrease in the AV node's conduction velocity, that is, how quickly impulses travel through the AV node. There are only two significant indications for Digoxin: atrial fibrillation and atrial flutter with rapid ventricular response, and heart failure with reduced ejection fraction. However, due to Digoxin's extensive toxicity, it is considered to be a second or third line agent and is usually not used unless both of the above indications are present. As already implied, Digoxin is one of the most toxic of antiarrhythmics, has a very narrow therapeutic window, and is particularly dangerous in patients with unstable renal function. It also has many drug-drug interactions. Dig levels can be checked, but usually only the upper limit of the therapeutic range is of interest. In other words, if a patient's serum Dig level is in the toxic range, a dose reduction is warranted. But the dose is not increased if the level appears to be subtherapeutic, provided that adequate clinical response seems to be present. So, what does this awful toxicity profile look like? First, presentation of Dig toxicity varies depending on whether toxicity is acute or chronic. However, cardiac toxicity is present in both situations. The cardiac toxicity of Digoxin consists just of its proarrhythmic effects. These are related to one of two mechanisms. First, the effect of increased vagal tone in cells expressing the slow action potential, such as the sinus node and AV node. Second, as was mentioned a minute ago, the increased intracellular calcium, or more specifically the intracytosolic calcium that was helpful for increasing contractility, leads to delayed after depolarizations. The proarrhythmic toxicity of digoxin increases with hypokalemia, hypomagnesemia, and hypercalcemia. Non-cardiac toxicity of digoxin includes GI distress, as well as a broad range of neuropsychiatric problems such as dizziness, fatigue, depression, confusion, and a variety of visual disturbances, including altered color vision. Digoxin toxicity is associated with almost every arrhythmia, but there are several which have a particularly strong association. In other words, if you see any of the following rhythms in a patient known to be on digoxin, you should immediately suspect dig toxicity. First are two that are associated with AV block from excessive vagal tone: atrial fibrillation with an unusually slow ventricular response, and AFib with complete heart block and an accelerated escape rhythm. And the next two rhythms are from digoxin causing delayed after depolarizations: atrial tachycardia with 2:1 AV block, meaning only one of every two ectopic P waves are conducted to the ventricles. And last, a particularly distinctive rhythm called bidirectional ventricular tachycardia. This rhythm is a special case of VT in which the ventricular beats alternate between two different morphologies and which can easily be mistaken for ventricular bigeminy. The second drug to discuss is adenosine. Adenosine is a purine nucleoside, the same one that's in RNA and ATP. The primary antiarrhythmic action of adenosine is to suppress AV nodal conduction, that is, it induces AV block and does so very dramatically. A less important action is to suppress automaticity, and a non-antiarrhythmic action is the dilation of coronary arteries via smooth muscle relaxation. So, what are the indications for adenosine? Well, in general, as an antiarrhythmic, there are two. The first is to terminate reentrant rhythms that depend upon the AV node. These include AV-NRT and AV-RT. If you want to know more about those rhythms, there will be relevant links in the video description. So here is an example of an unknown supraventricular tachycardia that was suspected to be an AV-NRT. A rhythm strip was continuously recorded during adenosine's administration. So what's going on here? Well, adenosine was given approximately here, and as you can see, the tachyarrhythmia terminates here. Then there is a pause in which there is no electrical activity in the heart at all for nearly 2 seconds. Then what appears to be a sinus P wave that demonstrates the sinus node has recovered from the overdrive suppression caused by the tachycardia, but the AV node hasn't recovered yet, so the sinus P wave is blocked and not conducted to the ventricles. But then after about another second, there is another sinus P wave, and this one is conducted, showing that the AV node has recovered. The arrhythmia has terminated and the patient is back in sinus. The second indication for adenosine is to uncover hidden atrial activity in known supraventricular tachycardias to aid in diagnosis. This is particularly helpful when trying to distinguish atrial flutter and atrial tachycardia from other rhythms. So here is part of another rhythm strip. It's difficult to tell what's going on here with any degree of certainty. There are definitely some extra waveforms that are in the beginning of the T wave that are suggestive of atrial activity, but you can't be certain what's going on when the rate is this fast. Adenosine is given here, and after just a second, AV block kicks in, and the underlying atrial activity is revealed. In this case, the extremely rapid rate of atrial activity is indicative of flutter. Then, since the ventricles haven't seen any activity from above, a latent pacemaker located within the ventricles starts to spontaneously fire, giving you what are called ventricular escape beats on the EKG. Then the adenosine starts wearing off with one conducted QRS complex before the patient falls back into the previous tachycardia, which you now know to be atrial flutter with 2:1 AV block. Since no part of the reentry circuit of atrial flutter is located in the AV node itself, adenosine does not terminate the rhythm. It just very briefly blocks its transmission to the ventricles. One of the most unique aspects of adenosine's pharmacology is its very short half-life, on the order of seconds. Therefore, if delivered too slowly, by the time the medication has been fully injected, the first portion of it has already been metabolized. So one must adopt a slightly unusual means of administration using a three-way stopcock in which the drug, shown here as the small syringe, is quickly pushed. Then the stopcock is immediately turned to the large saline-containing syringe, which is then also rapidly pushed. Critically, heart transplant recipients are very sensitive to adenosine, and if you choose to use it on such a patient, the dose must be reduced. When it comes to the side effects of adenosine, the one that is experienced by literally almost every patient is that it creates a brief but incredibly profound sense of being unwell. I've had numerous patients tell me that they felt themselves dying, which makes sense because the drug literally induces cardiac standstill. The good news is that this sensation only lasts for about 10 seconds, though this can feel like minutes to the patient. So please warn your patients about this ahead of time. A bolus of adenosine has also been rarely reported to induce actual cardiac arrest. I've never heard of this happening with a patient at any hospital I've worked at, but because of the risk, you should always have a crash cart in the room during administration. And of course, they'll be on a cardiac monitor because it's critical to see and record what happens. Finally, it's considered contraindicated in patients with high-degree AV block or sinus node dysfunction, in whom the effects of adenosine may last longer than anticipated or desired. I'm going to talk about atropine and isoproterenol together, since they have overlapping physiologic effects and indications, as atropine antagonizes the parasympathetic nervous system, while isoproterenol is an agonist for the sympathetic nervous system. Atropine, more specifically, is an anti-muscarinic, which means it blocks acetylcholine's actions on the muscarinic receptors within the parasympathetic nervous system. Normally, the parasympathetic nervous system provides input to the sinus and AV nodes via the vagus nerve that essentially tell the heart to slow down a bit, both a slower sinus rate and decreased AV conduction. Atropine interferes with that signal, so predictably, its indications include symptomatic sinus bradycardia or symptomatic AV block. There's actually a bit of disagreement as to when atropine should be considered a first-line agent for these indications, or if it should be epinephrine or transcutaneous pacing as first-line agents. This is probably best considered on a case-by-case basis, depending upon the patient's blood pressure, signs of shock, suspected level of AV block, that is, where in the AV node His bundle complex the block may be occurring, and on the availability of pacing. For example, in a patient with type 2 second-degree heart block, in which the level of block is felt to actually be below the AV node, atropine is unlikely to help since there is no parasympathetic innervation there. Side effects of atropine are many. You may recall a mnemonic for the anticholinergic toxidrome: hot as a hare, red as a beet, dry as a bone, blind as a bat, and mad as a hatter. That largely describes the side effects of atropine, but the most clinically relevant acute side effects of atropine are various tachyarrhythmias and urinary retention. Other frequent effects include dry mouth, blurred vision, and confusion. There is one specific population that requires additional consideration. Atropine is completely ineffective in heart transplant recipients, as their transplants left them with no vagal innervation of the heart. Moving on to isoproterenol, also known as isoprenaline in some parts of the world. It is a synthetic catecholamine similar in structure to epinephrine and norepinephrine, but acts only on the beta-1 and beta-2 receptors with no significant alpha effect. It is used as a second or third line agent in torsade de pointe. In Lesson 4 on the potassium channel blockers, I discussed the concept of reverse use dependence, in which the effect of class 3 antiarrhythmics was greatest at slower heart rates. So when a patient presents with torsade due to medication toxicity, increasing the heart rate will help to limit the effect of that causative med. It's generally used as a temporizing measure while temporary pacing is getting set up, which itself is only done if the first line treatment for torsade, magnesium, has already been insufficient. In the past, isoproterenol was also used frequently for treatment of symptomatic sinus bradycardia. However, it is now very rarely used for this purpose due to its side effects. These include hypotension due to the beta-2 agonism in the absence of alpha agonism, various tachyarrhythmias, angina, restlessness and anxiety, and tremor. It just makes people feel revved up and lousy. And the final drug to discuss in this video series is Ivabradine. Ivabradine is a more recently developed antiarrhythmic approved by the FDA here in the US in 2015 that is unique in its mechanism because it inhibits the so-called funny current. I have not mentioned the funny current since lesson 1, so let me remind you. In myocytes within the sinus and AV nodes, where the slow response action potential is expressed, the resting membrane potential is not at an equilibrium. There is actually a small depolarization current called the funny current that is carried by sodium and potassium ions. When the spontaneous depolarization of the cell hits a certain threshold, the L-type calcium channels open and the full action potential is triggered. This is the mechanism responsible for pacemaker cells' normal automaticity. Ivabradine, by blocking the funny current, decreases the rate with which these cells spontaneously depolarize. In other words, it decreases normal automaticity, the primary consequence of which is slowing of the sinus rate. Ivabradine's indications include heart failure with reduced ejection fraction in patients who remain with an elevated heart rate despite beta blocker therapy. It's also used in stable angina for patients who are intolerant or with contraindications to beta blockers, and in a condition called inappropriate sinus tachycardia. I don't know whether it's because doctors don't really know about it yet, or because they aren't convinced by the available evidence, but Ivabradine is still a relatively uncommon drug to see used in clinical practice. The most common side effect of Ivabradine is pretty predictable: sinus bradycardia and sinus arrest. Other notable side effects are that it increases the risk of developing atrial fibrillation, and it also causes a visual disturbance called phosphenes, which are visual disturbances characterized by areas of unusual brightness in the field of view, halos, or transient splotches of moving color and light. That's it for this video on the unclassifiable antiarrhythmics. The next and final video will discuss how to choose the appropriate antiarrhythmic in specific clinical situations, as well as some common pitfalls with antiarrhythmic therapy.